Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca. Hello, everyone, and welcome to this edition of Children's Healthcare Canada's Spark Live webinar series. The Spark theme for October is Protecting and Promoting Child Health, and I'm Paula Robeson, your host for the next hour. We'd like to begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to Ottawa. Today, Ottawa is home to Indigenous peoples from across Turtle Island. Children's Healthcare Canada is committed to working towards forging new and deepening existing relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land as we work to measurably improve children's health outcomes from coast to coast to coast. We're delighted to speak today with Dr. Patrick McGrath to bring you Paraprofessionals, a needed resource in the child and family mental health care. This webinar is offered in collaboration with our partners, the ChildBright Network. Dr. Patrick McGrath is a practicing clinical psychologist, a researcher at IWK Health Centre, and an emeritus professor of psychiatry at Dalhousie University. He co-founded the Strongest Families Institute and is chair of their board. His research, mentorship, and healthcare leadership have been recognized by appointment to the Order of Canada and election to both the Royal Society of Canada and the Canadian Academy, my goodness, of Health Sciences. He won the Manning Governor General's Award for Innovation and the inaugural Legacy of Leadership Award from Healthcare Can. At ChildBright, he's the co-principal investigator of the Strongest Families Neurodevelopmental Program research project. His extensive career has included being a clinician, a researcher, an administrator, and a social entrepreneur and disruptor. He has failed many times and succeeded a few times. It's now my pleasure to pass the mic to Patrick.
Thank you very much. I guess what we first of all have to do is share my screen. So I wanted to talk today with you about paraprofessionals. And is the screen right? There it is. And I think they're a needed resource in child and family mental health care, and actually one that we don't use enough. So my agenda for today is to give you an introduction to the area, advantages and disadvantages of paraprofessionals, some of the models that are used in developing this, training, supervision, monitoring, and then what I perceive that might be the future. First of all, what is a paraprofessional? Well, comes from the Greek word meaning para, which means sort of alongside, and it's a person who works alongside a professional. They're not licensed. There's no agreed upon background or training, and they're not generally independent practitioners. There are some groups that originally started as paraprofessional that now have become professionals. So paramedics, physician assistants, paralegals are all now licensed, and they have their own regulatory bodies and training programs and so on. Psychotherapists and counselors are on the border. In some provinces, they are licensed, and in other provinces, they're not. And I'm trying to go to the next slide. There it is. So the paraprofessionals are very widely used in low and middle income countries because there's a scarcity of health professionals and a great demand for services. And I'm sure that many of you recognize that that's exactly the case here in Canada. Sometimes they're called lay health workers, community health workers. They're widely used, paraprofessionals are widely used in Canada as teachers' aides, and many classrooms have a teacher's aide, and these are very often classified as paraprofessional. They're used in some aspects of our formal and informal health system in Canada. So, for example, applied behavior analyst at one time is a paraprofessional, just now become a profession in Ontario. Mental health worker, sometimes counselors are called are not licensed, psychometrists, psychological associate, which is a profession in Ontario, psychology aide, psychology assistant, therapist, lay worker, lay counselor, assistant, or coach. So there's many different names that are applied. So first question now, what has your experience been with paraprofessionals?
Feel free to poke your answers into the chat box. Oh, there's
There
the
it is.
webinar poll. There you go.
And the results are 63% have paraprofessionals in their unit, and an additional 16 said no, but we should. And most people think that there is a role for paraprofessionals in mental health. So now why I'm having such difficulty forwarding my screen, but I apologize. There. So there are different models that have been cited in the literature and used. One of those is facilitative to treatment, where paraprofessionals socialize clients to treatment. They take history, they may do administrative issues, they may do translation. A second model is that paraprofessionals do additional interventions other than what the professionals do. So they might do in vivo exposures in anxiety treatment. They might provide social support for the clients. And the other one is task shifting, where specific tasks are shifted from professionals to paraprofessionals. Maybe as I mentioned, exposure in anxiety or training of skills in ADHD. Or they may do solo work with clients, taking on all tasks with the client. For example, parent training for disruptive behavior, or CBT for anxiety, or perhaps exposure treatment for PTSD. The training of paraprofessionals is varied, and I think it usually varies with the tasks that they're given. There's general training on preclinical skills, the skills that everybody should have when they're dealing in this situation, on information about and ideas about therapeutic relationships, and of course on ethics. And then there may be specific skills, for example, CBT basics, specific program. Examples might be parent training for disruptive behavior or anxiety, or written exposure therapy for PTSD. So these specific skills are usually added to the general training. Now, the methods of training vary a lot. In a program that I'm just developing right now is called Super Minds for superhumans. It's for a program that we're developing for a group in Ukraine. We spent about 10 to 15% on theory, 80 to 85% on practical issues. We use written material in plain language, and it's really important to use plain language. We use tables, figures, video clips in our written material. The lectures comprise about 30% of the of it with lots of examples. So we do use some lectures. Lectures are useful in some situations. And then we use role play and videos in about 50%. So a lot of actual hands-on experience, and that people have to reach certain criteria before they are deemed to be proficient. Second question. And we should be getting the answers pretty soon. So again, we don't have paraprofessionals in our unit. This seems to contradict the earlier poll, but that's what we do when we find we train exclusively in-house with structured training, 11%. We train exclusively in-house informally, the same amount, and we use paraprofessionals trained in community colleges, about 11%. So there's quite a bit of variety in this area. And once again, my slides seem to be sticky. There it is. So preclinical or general therapy skills. Now, the World Health Organization has and UNICEF have just recently released this training program with different modules, and it's an excellent program. In our work that we're doing for Ukraine, we're using mostly the bottom layer, and mostly we focus on nonverbal communication because people often aren't aware of that. How your behavior communicates to your client. We go over, how you put your face, what you say, or what your words communicate and the tone of words, and what you have to do to build a therapeutic relationship, really emphasizing empathy and warmth in both verbal and nonverbal. The therapeutic relationship is important, and I think this is important no matter how you deliver care. We've done some studies on therapeutic relationship in telephone delivered care with paraprofessionals and found a very high rate of therapeutic relationships. So the general things that are thought to be important in therapeutic relationships go back to Borden, 1979. The bond, the emotional attachment, trust, warmth, and caring. Goals, you have to agree on what you want to achieve, and the agreement of what you will do in therapy, the tasks. We emphasize to our paraprofessionals that the therapeutic relationship is different than friendship. It's a professional business relationship, and it's focused on improving the life of the client. That there are certain boundaries that we set with paraprofessionals and with our clients, and it's collaborative, but there's clearly a difference in the power relationship where the client discloses more and the paraprofessional directs more. So we put a high emphasis on ethics, and I would commend to you the Canadian Code of Ethics for Psychologists. Can be used in many, many different areas. And it really focuses on principles rather than specific rules. There are some specific rules, but they're basically the principles are what's important. And these are hierarchical principles where the first principle is respect for the dignity of person and peoples, the inherent worth, non-discrimination, the moral rights of our clients, and natural justice. So the second principle is responsible caring, and focusing on the competence, that you have to be competent in what you do, maximization of benefit, minimization of harm, and again, respecting the dignity of people, the integrity in relationship, and responsibility to society. And responsibility to society is important, but these are, as I mentioned, are hierarchical. And if there's a situation where responsibility to society says you should do one thing, but the principle of respect for the dignity goes against it, would tend to favor the first of the principles rather than the fourth. The safety of clients is extremely important and should be given a lot of attention in any program of training. So we use the NIMH Suicide Prevention Guide. You have to keep them safe, ask them about suicide, and there's no evidence that asking people about suicide increases suicide. In fact, it may decrease it. We have to keep them safe. We have to be there. We have to help them connect. We have to stay connected with them until they get help. The other thing is, of course, with paraprofessionals is the supervisor should be notified immediately if there's any indication of the threat of suicide. The advantages of paraprofessionals are they can be trained in working within weeks or months. And of course, it takes years to train a professional. They tend to be paid less, so then they're less expensive than professionals, even incorporating maybe the higher rate of their higher demand for supervision. They may follow protocols better. And I'm a great believer in protocols because that's how we know what we're doing is effective. And there is some evidence that paraprofessionals may follow protocols better. I remember once when I was talking about strongest families to a group of psychologists in Nova Scotia, and one person, piped up, "You mean I went to school for 15 years, in 7 of those in graduate school, and you're telling me that I should do this in session 1 and that in session 3? I want to use my clinical judgment." So there is often that feeling among professionals that they do not follow protocols. And the evidence is that indeed professionals in mental health and in other areas of health do not follow protocols very well. Paraprofessionals may accept detailed supervision better. And again, there's not been a lot of studies on this, but again, it's linked with the idea that they are more willing to follow protocols, and part of your protocol is detailed supervision. They may be from the same social group as the clients, and thus better able to understand the culture and be more familiar with the stressors as well as the strengths of the clients and the communities. The risk, of course, is that paraprofessionals may over-identify in terms of not being able to keep their own needs separate or their own understanding separate. And again, that's something that has to be very carefully managed. Some disadvantages, other disadvantages of paraprofessionals is they're less well-trained, of course. They may miss important factors. And so you want your training program to make sure that they do have a strong background and availability of supervision. They very often have less understanding of theory. Theory is helpful because it often helps you understand that something that looks novel is actually not novel, but part of the whole picture. More narrow training, again, you may be trained in one approach, but you will not know the other approaches. So they have very limited options in treatment, and they may not have as deep an understanding of ethical issues or be subject to more challenges. They may have more of if you're a member of a community, you may have a dual relationship with that person. And if you're not very careful, you may confuse the boundaries. It's risky that paraprofessionals may not recognize their limitations and seek help when they need it, but that's true of professionals as well. Paraprofessionals are restricted from some acts. For instance, they cannot do diagnosis in most provinces, and they can't do psychotherapy. Final thing that I think we have to understand is that there's a risk that we will exploit paraprofessionals because they may not be appreciated, they may not be paid reasonably well. They may be just seen as professionals, as substitutes for professionals, taking it another way, and this is not the case. So what do you think is the biggest advantage of paraprofessionals in your context? The answer should be appearing soon. So the 8% said short training, 8% extend services, increased diversity of treatment staff is seen to be as a major advantage. Not well enough trained, a concern of 15%. Not a concern of ethical risk or regulatory risks, and resistance from current staff, 15%. So you see that there's a range of concerns and a range of risks.
There's a comment as well in the chat box, the addition of frequent staff turnover and low pay.
Yes, and that would depend on what you pay your staff. And if you pay them well, relative to options that they have, then I think you're going to have a much better chance of keeping them. And I think turnover is an important issue even among professionals, where if a professional, for instance, in a hospital, and this is very true of the case of psychologists, that they make a lot more if they're in private practice than in the hospital, there may be turnover there. So I think payment and a sense of being part of the team are really important, and making sure that that paraprofessionals aren't overburdened with the number of clients or the difficulty of clients, so that they get the support that they need. Moving on to supervision, the major goal, I think, is that to ensure that tasks are completed according to protocol. And I really believe that you have to have a protocol. You have to have clear indications of what people are supposed to do, and to support the paraprofessional. You can use case review, you can use real-time review with or without instant feedback, and review of tapes. These are all expensive to do, but important to do. And they can be very much done on a sampling basis. You don't have to perhaps review every case every week, except to see if there's any difficulty with them. The review of tapes, either videotapes or audio tapes, is tedious and difficult, but again, a sampling approach and a checklist approach can be done. In Strongest Families, for instance, we have other coaches doing some of the review of protocol review when they review the cases with the person in terms of reviewing the tapes. We have specific things you're supposed to cover, and if you're not covered, then it shows up quite well. So the peer supervision and peer support is useful, and I would recommend that if you have paraprofessionals, that you have a program of peer support and probably some peer supervision. And as I mentioned, the lack of professionals and the time and resources to do supervision are major problems. So monitoring is important. Now, that's not typically done with professionals. There should be, not just for supervision, but there should be monitoring, and these two functions can be combined, but there should be monitoring to make certain that you're following appropriate protocol. Ongoing monitoring of client outcomes is important. It's important with professionals as well, but not always done. And ongoing monitoring of client satisfaction is important. These last two monitoring features can be done very quickly by having clients complete very short scales, and there are some commercial setups. For instance, I use in my clinical practice, I use GreenSpace, which is they provide automated presentation of short scales, such as the generalized anxiety scale. And ongoing monitoring of client satisfaction, again, with 3 or 4 or 5 items, has been shown to be effective. So we want to keep monitoring, and we have to have a very good IT system that is able to do that. And because we don't want to have pieces of paper hanging around and having to tally them all up. In the program that we're developing for Ukraine, we use we'll be using RedCap to do that. And RedCap is an IT system that's available to any nonprofit, It's mostly used for research, but very good for this type of thing. So the one thing I want to also emphasize is that training somebody one time and then releasing them to, it's not a very good practice. It's a bad practice. So train and release, as it's sometimes called in the field, is not a viable approach where you just train somebody once and then you hope that for the next 10 years that they'll do a good job. How strong is the evidence? Well, there's virtually no direct comparison of professionals versus paraprofessionals. There are some, but not a lot. And they shouldn't be seen as a replacement for professionals, but we do have some evidence that they can do certain things as well uh, as professionals. So there's a systematic review on paraprofessionals delivering care, not necessarily compared to professionals, but showing that they're effective in things like behavioral activation, in parent training, in motivational interviewing, in PTSD, and in anxiety. So one example, as I mentioned before, is Strongest Families. Strongest Families began as a research program funded by CIHR within my research group, and then was spun out into a not-for-profit. And we have about 12,000 plus families per year and 100 or more employees. All interventions are on telephone with a personalized website. We've published on the IT system that we developed, proprietary IT system that we developed for that. And supervision is by senior coaches, not by professionals. In my own research group, the Center for Research on Family Health, we have done recently PTSD intervention with coaches online, using video online, and using some support of a website. So this is examples from my own experience that we've used, and there are numerous examples across the country. In the future, I would like to see more advances in artificial intelligence, for example, to analyze videotape recording so that it highlights things, not that it does the supervision, but it highlights things that have to be looked at, and further personalization of interventions using AI of different sorts. The question arises all the time of whether or not there should be more professionalization of paraprofessionals. Should they be educated in college programs? Should there be certification? Should there be regulation? And as I mentioned, Ontario has recently gone for applied behavior analysis being regulated as a regulated health profession. They're part of the College of Psychologists now. The big disadvantage is it probably is going to raise the costs to the paraprofessionals, but also to the units that employ them, and will increase, though, on the other hand, mobility and wages. If you're being trained by a unit, you have to invest in this, because you can't just have it off the corner of everybody's desks, because specific skills are needed and you need some training resources.
And I have a few questions here, and I'm waiting for others to come through. Have you developed, Patrick, any curricula for the training of these paraprofessionals or their ongoing professional development?
Yes, with Strongest Families, we have a curriculum and a training, but it's a proprietary training. It's not we haven't published it, and it's not freely available.
Okay.
With the project that I'm doing right now, with Superminds, we're in the midst of developing the curriculum, and our intent is to license it with Creative Commons, I think, which will depend partly on our Ukrainian partners, but we'll be developing it in English, translating it to Ukrainian, and then we should have this ready in about 6 months or a year. And this will be a more broadly focused, because we have a set of modules both for the person who has had an injury in Ukraine, when we're focusing on in a hospital that has amputees and maintains prostheses, but it's not going to be focused on prostheses. It's going to be focused on issues such as PTSD, anxiety, depression, substance abuse. And we'll have one coach for the identified patient and one coach for the family. Again, with many of the same issues. So I don't have a curriculum to give you right now. I would commend you to the curriculum for the preclinical skills that was just recently released by the World Health Organization and UNICEF, which is in one of the slides, and the references are on the slides.
Thank you. Rebecca has a question. Have you had to navigate any challenges from unions when introducing paraprofessionals?
I haven't in my own work, but I know that there will be, and it's likely that there will be. That the challenge is simply where do they fit in the employment structure in the hospital. There's no reason why they shouldn't be unionized like any other worker in a hospital or a health system, or many other workers in the health system. So I would not see it would be a problem. It would be important that they be given the same rights as others. When I do research at the IWK, unfortunately research employees have no security, and it all depends on me getting more grants. So they don't have union rights, but they have some of the, depending on how they're hired, they have some of the benefits of regular employees. In Strongest Families, it's not unionized, but they have very strong benefits, and they have we use the same benefit package that is used for the health system, and so they have very strong benefits, including pension and health benefits.
Thank you. Always a question that comes up in mixed or unionized environments. You talked about supervision from a professional and also from a coach. Are they the same person? Are they different people? Is there guidance to those supervisors/coaches to help with paraprofessional development and improvement?
Yes, you have to prepare staff who are supervising as supervisors, and this is the important aspect of having a formal program of supervision, and it's necessary to do that. In Strongest Families, the supervision is given by senior coaches, and so they're not professionals. The CEO is as a nurse. I'm chairman of the board, but I don't have any direct work on the day-to-day operations. So there is supervision by both other paraprofessionals, and supervision in other settings. There may be supervision by a psychologist or a social worker, and I wouldn't say that there's any evidence one way or the other. It really depends on the setting.
Another question. What have you found are professionals' acceptance of paraprofessional colleagues? Is there anything we can do to increase their readiness or acceptance, or is it not an issue?
Oh, I think it is an issue, and it will depend if the professional feels threatened by paraprofessionals, and I think that it has to be introduced in a way of it being part of the team and being able to extend the ability to serve our clients. It's typical that there are long waiting lists in children's and adolescent mental health, and that's often a very important motivator for when there aren't enough professionals. We have to have another way of meeting this need. Mm-hmm. And just by asking the government for massive increases in funding, which, by the way, are necessary, but is in these days, it's very unlikely to get a massive increase that will satisfy the need for services. So I don't think that we can solve the problem just by complaining to government. We have to solve it by multiple ways, and paraprofessionals are one very important way.
And how do clients feel about professional versus paraprofessional? And or do they notice? Do they make comments? What's their
Well,
experience of care?
I think certainly it's important to make certain that people know the difference, that they're being serviced by a paraprofessional. A coach is the term that we use in Strongest Families. Their experience is very good if the paraprofessional is well trained and working within their competence. There will be some clients that say, no, I don't want to be seen by a coach. I want to be seen by a psychologist. Or in the practice that I work in, we have both psychotherapists who are a profession in Ontario, and psychologists. And some people will say, well, no, I want to be seen by a psychologist, not by a psychotherapist. And so, these are individual choices that, if we can accommodate them in the health system, in the health center that we're in, that would be a good idea. But very often we can't accommodate, as much individual choice as it would be nice to be able to have. So there is some resistance at times, but oftentimes the paraprofessionals focused get to be very good at what they do. They may have a very focused practice, and they become very expert in that. And generally, we found very high rates of satisfaction.
And is part of your evaluation of this model outputs around the experience of care and of course ultimately outcomes, but I'm curious about measuring the experience of care in this context.
In the slides I mentioned both outcomes and satisfaction with care.
Okay.
But I think both are important. And it's all very well to be very happy with your therapist, but if you don't get better, then it's not the therapeutic endeavor is not working well. Not that every patient in every circumstance or every client in every circumstance will have a strong reduction in their symptoms, and satisfaction with the therapist, with the coach or psychologist or whoever, is an important piece of information to collect. There is sometimes resistance by professionals to, and they say, oh, well, I'm not in a popularity contest. But the best way to influence the behavior change, of course, is that if you have a good relationship with your client or patient.
That makes perfect sense. And
but these aren't often these aren't measured,
right?
And they should be.
Yep, I wholeheartedly agree. This is the last question, so it's my prompt to anyone on the line to type away now, or this will be the last question. You mentioned paraprofessionals not understanding the online theory or rationale for what they're doing. What do you do to help them understand that underlying theory? Is it important that they do? Is there any difference in their care if they don't? And how about understanding their roles and how what they do fits within the rest of the team, what the rest of the team is doing?
Yes, I think that's very important. Let's talk about the theory first of all. If I'm delivering for example, we're about to start a study on PTSD in teenagers, and we have the therapists or coaches, and they're delivering written exposure therapy online. So we have both distance intervention and coach intervention as somewhat novel parts of it. If the coach doesn't understand the basic theory of of treatment by exposure for PTSD, they're not going to be able to understand, if something comes up that's a little bit different they won't understand how it fits or it doesn't fit into the intervention. So it's extremely important for them to understand it, but they won't have the 3 or 4 year-long courses in psychopathology, so they may not recognize some things as being important. So they may although we would train on we would train very much on disassociation in a PTSD intervention. What's the difference between disassociation and hallucinations? And we will cover some of that, but there's always a borderline in some of these issues, and they may not understand it as well. So fitting in with the team and knowing that they have somebody that they can go to that will be able to answer those questions and to be able to help them distinguish between these different issues is really important. So they have to you can't just train them in one tiny area without trying to get the theory and understanding. But at the same time, you're not going to be able to spend a year or 2 year training them so that they really understand all of psychopathology. At the same time, you have to have people who are supervising, who are more knowledgeable and can answer questions about the larger issues for the cases that aren't following the textbook.
That makes sense as well. And I assume that's part of what the coach will do, the senior coach will
Yes,
do.
the senior coaches in Strongest Families, and in the case of PTSD, because it's a relatively new thing, there isn't a lot of experience about PTSD. There isn't a lot of experience. There's some with training coaches to do PTSD intervention. Then they will have access to psychologists with extensive experience with PTSD.
Thank you. Well, that's the end of our time together today. Thank you, Patrick, for sharing your time and
Well,
expertise
thank
with
you.
us. It's a pleasure. And thank you to our audience members for joining us. We know how busy you all are right now, and we hope you depart with some practical knowledge to bring back to your organization. Upcoming on Spark, we have a busy fall here at Children's Healthcare Canada, and it's chock full of offerings. In October, even though there's only a few days left, on Friday, October 27th, join us in Ottawa and virtually for Inspiring Healthy Futures, a Future Fit for Kids Summit. Visit our website for more information. This event is for you if you're interested in shaping future research, advocacy, community innovation, and system change for Canadian children, youth, and families. On Spark Conversations, our podcast series, we're bringing you on October 30th, Integrating Pediatric Social Determinants of Health for Children in Canada. And that episode will be our season 3 podcast host, Dr. Catherine Smart, in conversation with our special guest, Dr. Justine Cohen-Silver. We are also on a mission to right-size health systems serving children and youth. And we're involved in a series of virtual roundtables that are taking place between October 20th and November 2nd, and are designed to identify key areas of opportunity where recommendations for policy and investment will make the greatest impact. These interactive roundtables are open to anyone delivering or responsible for the delivery of healthcare services to children and youth, as well as youth and family partners. And again, more details can be found on the Children's Healthcare Canada website. In November, we've got more webinars planned. We have a Spark Live feature, Can a Room Reduce Pain? Co-designing hospital spaces with children, families, and the healthcare team with our partners from Sick Kids. And in Spark Conversations, November 27th, we'll be releasing Navigating the Child and Youth Mental Health Crisis, Challenges and Opportunities, where Dr. Catherine Smart speaks with Dr. Javid Sakara on child and youth mental health. And finally, in December, we're bringing you our annual conference, Flip the Script, High Performing Health Systems for Kids, happening on December 3rd to 5th at the beautiful Hyatt Regency in downtown Vancouver. We also have a real-time virtual option that's available for those who can't join us in person. In addition to the conference, we're also hosting the Child Health Hub in Transition to Adult Healthcare. It's a pre-conference pop-up event called Ready, Set, Go Finding positive solutions to support a successful landing in the adult world. That's taking place in association with the conference on December 2nd and 3rd. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our website. Thanks again for joining us today. Thank you to Dr. McGraw for this presentation, and hopefully we'll see many of you back here soon. Bye, everyone.